Good afternoon, everyone, or evening, or whenever the heck you are listening to this. I'm Elizabeth Barchi. Some of you guys may know me. I'm from Primary Care Sports, and today I'll be talking to you about concussion, burner stingers, some C-spine injuries, and a few surprise nerve injuries that I threw in there just for funsies. So let's get started. So first thing, burner stingers. So this is the classic dead arm. So it's a transient brachial plexus neuropraxia. It usually gets better within minutes to hours. It'll present, you'll be covering a football game and one of your high schoolers will come off the field and be like, "Doc, I can't move my arm." And so then you'll take a look and be like, "Oh yeah, that's burner stinger." It's most common in collision sports such as football, so that's where we're going to be thinking about it most. And having one stinger statistically increases the risk of another stinger by threefold. So that's something to bear in mind. They could be a repeat offender. Burners and stingers are caused by a couple of different mechanisms. Most commonly, it's the traction injury. So this is the one that we often think of where you have the downward displacement of the arm with the side bending of the neck to the contralateral side. So they're being stretched. That brachial plexus is being stretched, excuse me. Another mechanism is, of course, the compression, which is the opposite. And so where you're crunching the brachial plexus between bony prominences and soft tissue. And so that can happen as well. And then, of course, there is the direct blow, which is, to Erb's point, just superior to the clavicle. So any of those three mechanisms are possible for creating this type of injury. It's important to remember that both the motor and sensory are affected. So they'll come over and be like, "Oh, my arm's dead," because it's going to be a lot of numbness, tingling all the way down the arm. They'll have weakness as well. So it's both motor and sensory that's involved. It's also important to remember that it's unilateral by definition. So if it's bilateral, that is pathognomonic for something else. And so remember, especially on boards, oral boards, not that I've taken oral boards, but hey, just remember it's a trick because if it's bilateral, it's not a stinger. It's something else that we'll go over later. And so you'll get tingling in the arm that's typically not dermatomal, although anything is possible. It's just classically not. And you're going to get transient weakness, as we said before. So mostly C5 and C6. Deltoid, biceps, sometimes rotator cuff muscles are the most common. You're going to have full range of cervical motion because, again, it's not a cervical injury. So you're not going to have C-spine type signs on exam. They're generally going to be non-tender. And the Sperlings can be positive if the injury is close to the nerve root. If you think of the mechanism of a Sperlings, this makes sense. When do we image? Well, we get x-rays if we've got recurring symptoms. So remember, this is one of those gray areas because if we remember a few slides ago, we said statistically you're 3 times more likely to get another stinger if you've already had one. So in this instance, it's one of those where you start getting suspicious, where it's just constant. And so you want to rule out fracture or stenosis. If you have those bilateral symptoms, remember that's pathognomonic for something else. So you're getting an MRI to rule out spine pathology. And then also you can get an EMG if the symptoms are lasting more than 3 weeks, because at that point it's not necessarily a transient neuropraxia. We're worried about something more. How do we treat these? We just let them sit there and eventually it'll go away on its own. So they can return to play when there is a complete resolution of symptoms. That means they're fully strong, they have full sensation, no tingles left, and they have full range of motion of their upper extremity. Some contraindications to returning to play. Recurrent symptoms. So if it keeps happening, especially within the same game, get suspicious. And make sure you pull them and have them get x-rays just to clear the C-spine. If they have bilateral symptoms, we'll say it one more time, pathognomonic for something else. And so you want to work up that C-spine before you ever let them back in the game. And then, of course, prevention. So neck collars can actually be very helpful. They can limit the amount that the head can be moved to one side or the other, so limiting the compression type injuries. It covers Erb's point, so it limits the direct impact, and it can limit the traction injuries as well. It can be useful. Speaking of cervical spine injuries, let's move on. There's a wide range. They're most commonly seen in contact sports for obvious reasons, but don't rule out things like diving, which can get really nasty actually. But they're common in football and rugby. They're less frequent now because of protective gear and rule changes, but they're still pretty common. So it typically occurs when you have an axial load of the spine with the spine in flexion. So a common mechanism that we can think of is spear tackling, where you're tackling head first into another body. And so naturally the head takes the impact, the spine flexes up into extension or flexion, and then you can develop this injury. And so over time with spear tackling as a normal technique, you can actually develop loss of your cervical lordosis and gradual stenosis called spear tackler spine. And that is actually a contraindication to playing contact sports. So if they're starting to develop that, that's a career-ending injury and they've got to look to retire. One injury, so we talked about what could it be pathognomonic for anything other than a burn or stinger? Well, it could be transient quadroporesis. Transient quadroporesis is like a concussion of the spine. It's pretty rare, and it will occur in about 6 out of 10,000 football players. And it's caused by axial loading with the C-spine inflection or extension, usually something like spear tackling. And so it's a sensory and or motor abnormality in your either bilateral upper, bilateral lower, or all 4 extremities. So this is one of our bilateral injuries that we can get. And so the weakness is usually moderate to severe, and it naturally self-resolves in minutes to hours. It can last up to 48 hours, which can be particularly scary for the athlete involved to have, especially if it's all 4 extremities and they can't use it for 48 hours. They may never want to go back again. It can be really freaky. And so this is one to bear in mind. Bilateral can be motor and or sensory, but it could be one or the other, and it can come in a variety of ways, but it's bilateral. So when a player is down on the ground and you go to assess for a cervical injury, first evaluate the mental status. If the mental status is altered, particularly if they've just sustained a new concussion, that can be really difficult to assess. So if they're kind of hysterical, if they're sort of crying like, oh, what's going on? Just assume that there is a cervical spine injury. If they're yelling at you that their neck hurts, that's generally a good sign that there's probably something going on back there. So first you want to evaluate mental status. If there's any kind of altered mental status or they're not able to focus or calm themselves down, you have to assume a C-spine injury until proven otherwise. And then you just want to ask them about neck pain and any neurological symptoms like numbness, tingling, running down their arms, or weakness. When you're there, after you talk to them, first thing you want to do is stabilize the head and neck, which we remember from our trauma rotations where you put your hands underneath and your hands are on the back of the body, the upper shoulders, and your thumbs are on the front, and you're using that cupping position to stabilize the neck and head in your hands against the body. And so you want to, no matter what position they're in, you want to stabilize the C-spine, and then you want to roll them into a supine position. It's really important to remember that you're not going to remove the helmet and the pads. There's a tool called the Angel that can be used to remove the face mask if you need to access the airway for whatever reason. But unless you're going to put a C-collar on them, you do not remove the helmet and pads. You just spine board them in what they're currently in because it keeps them in a neutral position of that spine. And so you want to log roll them onto the spine board. Now, if you're in New York City, they actually don't spine board. And so you would be in the position, what they do is they put a C-collar on and they have you walk onto the gurney. And so what you would do is actually, that's the point where you would remove the helmet and the pads, but you do so with at least 3 different people, one always supporting the head and neck, stabilizing the C-spine, and then 2 other people working to remove things. Because you just don't want to move something if you don't know if there's an unstable fracture there. Once you get them off the field, you want to look for any kind of deformities, palpate the spinous processes for pain or step-offs, and you want to do a neuro exam of all 4 extremities, including reflexes. That's something that's really important. You can also see here in this picture that a beautiful example of spear tackling, which is not done anymore, thank goodness. So we have fewer injuries, but when I was a fellow, I was covering up, it was a varsity football game for East Harlem Pride up way north of the city. And I heard it because I was watching the play, and this happened kind of next to me on the sidelines. And it was just this unmistakable crash of 2 helmets. They both spear tackled each other, helmet to helmet. And the one kid, we couldn't get up. We had to call 911 because he was hysterical, because he was also concussed, and he was crying that his neck hurt. And we naturally, in Harlem, do not have any spine equipment. So the only thing to do was to call 911. It was very dramatic. I don't like being dramatic in general, but that was... You couldn't do anything else because you had to ensure that the spine was stabilized. He did okay, thankfully. There's no injuries, but just remember that, got to look to it. So when do you get an x-ray? So if you have neurological symptoms, numbness, tingling in any of the extremities, or spine pain, pain with active range of motion, signs of transient quadroporesis, those are all indications to get a C-spine workup, and you just want to get a standard trauma series. You can also get an MRI too if there's bilateral neural symptoms, just to cover all bases, especially when having the discussion of when to return to play. Speaking of return to play, if you have a patient or an athlete who has had transient quadroporesis, concussion of the spine, if they have a normal MRI, then that's you can feel confident sending them back to play. If they have congenital stenosis that is stable on x-ray, then that's something that you would counsel them on the risk and document the crap out of that. But just, talk to them about all the risks that come with playing contact sports when you have something like congenital stenosis. But then, if they understand everything and you've documented it, then yeah, they can play. And then sometimes, when it comes to operating, I leave that to you guys because you're the expert, or the trauma spine people, you guys know. And really beyond anything other than a burn or stinger or transient quadroporesis with an absolutely stone cold normal MRI, I really refer everything just to cover your bases, especially in this litigious day and age. Plus, you also just don't want anything to ever happen bad to a kid. But yeah. Moving on, some things that they absolutely cannot play with, absolute contraindications to playing contact sports. Previous trauma to C-spine, and maybe they're not absolute, but they're strong contraindications. So if they've had a previous C-spine injury, fracture, or ligament sprain, that's something that they should really not go back. If they have cervical stenosis or Klippel-Feil anomalies, that's another reason that puts them at very high risk for severe injury. And then a couple other more rare ones like congenital odontoid hypoplasia or ossodontium, they can just add to the instability of the spine and just increase risk when playing contact sports. Okay, we're on to the miscellaneous potpourri. Yay! So the first one is the long thoracic nerve injury. And so this, as a review, long thoracic nerve, C5 through 7, with the CA contribution, about 8% of people. The injury really comes from mostly a repetitive stretch injury. So think your tennis serve, where the head is tilted back from an outstretched extended arm, puts a lot of pressure on that, a lot of tension on that long thoracic nerve. And you can get some fascial bands from the inferior brachial plexus to the proximal serratus anterior, which can just exacerbate this. It can also come from direct trauma, and remember, it is a really long nerve, so there can be compression at several sites. It typically presents with pain at the shoulder or the neck or the scapula, and it's exacerbated by activity or tilting of the neck. So I have a dancer right now. She's about 15. She's elite, and she's having scapular pain and weakness whenever her arms are in a second position. So you guys remember that from dance clinic. And especially in dance, you have the apomal tilt of the head, and so that just really sets her off. And so, she has that classic dynamic winging of the scapula. When she's at rest, her scapulas are medially winged, medial and superior. So that's the trapezius dominating. She's got weakness in her shoulders when I talk to her physical therapist, because I've only been able to see her virtually for this issue. And then when it comes to doing a wall push-up, she's got that midline superior directional winging of the scapula too, compared to the other side. Just like this picture, it's pretty classic. And so you can do an EMG. It will show changes. It depends on how badly they want a specific answer. Because when it comes to the treatment, it spontaneously resolves in up to 2 years if you stop doing the thing that's aggravating it. So modifying activity, they can still participate fully, but they just have to modify. Physical therapy is really great for working on those scapular stabilizers, especially the serratus anterior, which tends to be very weak, especially when it comes to that medial and superior deviation of the scapula. Bracing, controversial, hasn't really been shown to help all that much. And if it's really affecting their lives, you can always consider a muscle transfer, especially if it's been going on for a really long time and they've done a lot of quality physical therapy for it. So the PT, it's focusing scapular glides, you see that on the bottom, and then also serratus work, which is the side plank work. It's also good for the glute med and the obliques, but it also really targets the serratus anterior. So you can see those an example of some of the PT you would do. Next up on our potpourri adventure is the axial nerve injury. So as a review, it originates from the posterior cord, C5 and C6, innervates the teres minor and the deltoid. The etiology of this type of injury, it can be a contusion. Commonly, it's a stretch injury with an anterior shoulder dislocation. 48% of people who have had an anterior shoulder dislocation will have EMG changes of the axillary nerve. Fun fact for the boards. And then older patients are a particularly high risk for nerve injury with the dislocation. You can also have entrapment with quadrilateral space syndrome, and you can also have iatrogenic. So quadrilateral space syndrome, this is one where I'm sure if it's anything like the PEDS boards, they'll tell you that they had trouble giving the vaccine on the left side, and what's the cause? It's just something really stupid where you have to know that, like, oh, the vaccine would be given in the deltoid, and if they felt that it was inappropriate to give it in that particular deltoid, but the other one was fine, that's probably some sort of atrophy of the deltoid, which is caused by the axillary nerve. And so, what are the boundaries of the quadrilateral space? That kind of obnoxious third order thinking. So as a review, boundaries: medial is long head of the triceps, lateral humeral shaft, superiorly teres minor, inferiorly teres major, and lat dorsi. It contains the axillary nerve and the posterior circumflex humeral artery. This is a common one in younger athletes, 20 to 40 years old usually, and very typical in baseball players, much more common in baseball players. So maybe it'll be a 22-year-old baseball player can't get a vaccine in his right throwing arm. What are the, I don't know. So that's how it might show up, but it probably will show up because it's something that's not controversial and you can get a good question out of it. But what do I know? I've never taken them. So you can do an arteriogram with the arm and abduction and external rotation. EMG is usually negative, and the treatment, it's conservative versus resection of fibrous bands that are around the nerve and compressing it. So, you start conservative. If they fail, you move on. So axillary nerve injury, typically presents with deltoid atrophy. And there can be weakness with the deltoid, or it can be completely asymptomatic. I just had a patient present with this the other day where she had issues lifting her arm, another dancer, lifting her arm from low position to first position, so that from hanging down fingers towards the floor and the forward flexion up into 90. Once she got it there, she was fine. And she did have that deltoid atrophy. I think there's a couple of things going on. I don't think it's necessarily pure axial nerve injury, but she did have pronounced deltoid atrophy on exam. And so you'll have weakness with abduction, forward punching, and external rotation. You can have numbness over the lateral arms. She did not have this. She just happened to have the deltoid atrophy. And so you can also do an EMG with nerve conduction, and that'll show some changes too. This typically self-resolves over time. You just stop doing what's causing the issue, activity modification, and you can do PT to strengthen, all the muscles around it. And the typical course is that the posterior deltoid and teres minor will be the first to recover, followed by the anterior head of the deltoid last. This can take months, 3 to 6 months, and so if they're still working on it 6 months later, they've been doing a lot of quality PT and it's really affecting them, at that point, you can consider surgical options. And I'll leave that up to you guys. You're much smarter with that. So concussions, my favorite topic to talk about. It's actually my first topic that I became proficient at talking about, so that's why they always ask me to give talks on it. So when you're out in practice, if you're in academic medicine, be really careful about the topics you agree to give a lecture on, because, it will blossom and all of a sudden people are going to hear your talk. They're going to think you're great. It's so smart. They're going to send you all of their patients with whatever disease you were talking about. And before you know it, that's going to be your practice. So just be very careful. That was the advice given to me. In the first 2 years, I can definitely say that yes, that does come true. But thankfully I do enjoy concussions. It is an art form, so we'll talk a little bit about that. I'm not trying to complain, I'm just trying to give you some advice. Be careful what you talk about. So concussion, it's by the books, it's an acute transient impairment of the neurological function secondary to an impulsive force transmitted to the head. So this means it can be a direct blow to the head, or it can actually be a blow to the body. And they've even had incidences of figure skaters getting a concussion during their spins. So you've watched the Olympics, you've seen them do these intense spins, and they actually can get, they can have shear injuries to their axons, which is what the concussion is. Think coup, counter coup, when they're getting hit. I have a really great GIF, but it really messes up the recording, so I took it out. And it's just that jello of the brain going back and forth. When you hit it in the front, it slams into the back and it slams into the front again. It's the coup and counter coup areas. So 2 points of injury. It's important to remember they may not have a loss of consciousness. It's actually very common for them it's more common to not have a loss of consciousness than it is to have a loss of consciousness. Only about 10% actually do. And there's a lot, anywhere from 1.6 to 3.8 million sports-related concussions per year. And that's just what shows up in the emergency room. It can make up between 5 and 9% of all sports injuries. And it typically occurs in competition more than practice. And you can imagine if you were an athlete, you take a lot of risks when it comes to competition because it's all or nothing. You got to leave it on the field. Practice, you're working on some skills. You're less likely to take those risks. The funny thing is, in dance, it's actually the opposite. And you can imagine that most of the time when this happens, it's in rehearsal where they're learning new choreography, or it's crowded and so they get hit by somebody else, or they get dropped on the floor, run into somebody because it's a running pattern and they haven't worked out where the lanes are with traffic. And so they more typically happens during practice than in the actual performance. And usually, it's more crowded, they're more tired, that kind of thing. But it's just an interesting thing to think about. So pathophysiology, we talked about, it's direct blow to head, face, or neck, direct blow to the bodies, forces transmitted up to the neck. There was a study that just came out of Rutgers, it was last year, actually, last spring now, not even this spring, looking at female neck diameter and strength and correlating that to concussion rate. So that might be one reason why. There's a ton of reasons why they're more common in females. We'll talk about that on the next slide. But yeah, so down at the cellular level, a concussion really is an energy crisis. So you have an abnormal ion flux across the cell membrane. You have an altered release of neurotransmitters, so glutamine for the cognitive function, and you also have energy depletion, which makes you more vulnerable to second impact syndrome. What is second impact syndrome? It's the thing that keeps me up at night. We don't understand it. That's probably why it bothers me so much, is because we don't really know. We know it's more common in high schoolers than any other population. Maybe because high schoolers go unreported so much, I don't know. But it's where you have a rapid swelling of the brain to the point where it herniates. And if you make it to the hospital, the mortality rate is 50%. But even if you survive, I don't know how much work you've ever done in the ICU, but you probably have been around the hospital long enough to know that there are things worse than death. And even if you do get to the hospital and do survive, you're usually brain dead at that point or close enough to it, just a vegetable. So it's something I don't typically talk to parents about it that much unless they really need to understand the dangers of doing contact activity before the patient is no longer symptomatic. Because it's just something that's not commonly talked about. And it's just rapid brain swelling to the point of herniation, and it's uncontrollable. You can't really stop it. And so, yeah, I pull that one out of my hat whenever someone's being truly unreasonable. I'm like, well, they could die. So, it's a thing. It happens. Risk factors, contact sports, obviously. Don't forget about cheerleading. Cheerleading is a contact sport. I don't know if you guys have had a chance to watch cheer. There's plenty of orthopedic interest in that. Some of it kind of nasty, but it's a good one to understand their psychology too. A prior concussion makes you statistically 2 to 8 times higher or at greater risk for sustaining another concussion and also having prolonged symptoms too. So the idea is like with each successive concussion, you lower the threshold for another concussion and you run the risk of longer, more prolonged symptoms. We were talking about females have higher risk of concussion. Part of it is because, thought that just the physical aspect of it, because they have thinner necks, less strong necks compared to males in general. The hormones could play a role with it too. Also, we've been thinking about, are they more symptomatic at baseline? Are they reporting more frequently? There's a ton of reasons why females have higher incidence of concussion. Being younger, especially younger than 18, I think that this is probably because the brain is still developing so much. So if concussion is an energy crisis, you injure a brain that's already using up a ton of energy trying to develop, it's going to go into crisis much more easily. Plus, also, kids are stupid. They take a lot of risks that are unnecessary. Although adults are stupid too, I don't know. But some of the risk factors for just diagnosis and recovery and prolonged recovery: mood disorders, learning disorders, history of migraine. And why is this? Because if you think about all of the symptoms of a concussion, they're literally the same as mood disorders, learning disorders, and history of migraine: sensitivity to light, sound, with headache, nausea, vomiting, dizziness. It's all there. And so it gets really difficult to start teasing this stuff out, especially if they happen to be near puberty and they're developing a headache syndrome concurrently with their concussion injury. So it's important to ask about that in the history, but also family history too. And sometimes you just need to bring a neurologist on board to try and tease it out. So some of the symptoms, there's 4 different categories of this. So cognitive, so this is going to be the delayed reaction time. They may never remember the actual events surrounding the injury, and that's okay. That's not a prerequisite for them to return to play, getting their memory back, because that often they won't get it back. So say they can't remember the play of when they got hit, and a few minutes after that, it's just like a blank space if they went into the play, and then the next thing they can remember is they're on the bench. And then difficulty concentrating and remembering when it comes to school, or just like when you're doing the scat, which we'll talk about in the next slide. Headache is the most common of the symptoms. Nausea and dizziness also falls under physical. Emotional, they're often a lot more irritable than usual. They can be kind of depressed. A lot of my athletes will have this very flat affect when you walk into the room, and the parents real freaked out because they're like, that's not my kid. You're like, it's okay, your kid's gonna come back. And you can watch them become much more animated, throughout the follow-up visits. But if you're covering a team and you know the athletes pretty well, and someone who's usually pretty, animated and full of life is just really flat, something's up and you just gotta pull them out. And then nervousness and anxiousness too, which is endemic in our society. They'll have some sleep disturbance too, so they're going to be sleeping more or less than usual. They're going to have trouble falling asleep and staying asleep, and they're just going to have a lot of fatigue all the time. Everything's going to be a lot harder for them. So just preparing your athlete that these things are normal and they'll get better, but also try to help them tease out whether it's worse than their actual baseline, because we're all tired and lethargic a lot of the time. So we have to figure out, what's your normal lethargic and what's your concussion lethargic. It can be kind of difficult. So when you're evaluating these guys, so first thing, kid down on the field, we're rushing out, or you let your athletic trainer rush out and you jauntily stride out onto the field confidently and instilling confidence in the crowd watching your every move. Typically you don't go out unless the athletic trainer calls you out, but it depends on where you are, because sometimes you have to always go out. It depends on what the refs want of you. So the first thing you're going to do are your ABCs. You're going to do a cervical spine survey, and you're going to look for signs of brain bleed, because that's the worst possible case scenario. And so your dilated pupils, slurring of the speech, ataxia, and you want to leave them on the sidelines, or you want to leave them where you can constantly check up on them, because another sign of brain bleed is worsening symptoms. So if the headache keeps getting worse, they start vomiting and they can't control it, those are all red flag symptoms for brain bleed, and you want to call 911 right away. Never leave the athlete alone after the injury. Always have them somewhere where you can keep checking in and making sure they're doing okay. So once you've done all of these primary things, to answer the question, do I call 911 or do I not call 911? That's your first thing. Whenever you go out onto the field for an athlete who's down, your first question is, do I call 911 or do I not call 911? And if they don't have any red flag symptoms, then next step is your secondary survey. So you take them to the training room or somewhere quiet, and you do the SCAT-5, which is a whole slew of neurocognitive testing, and also a symptom checklist. So that you can get online. You can just Google SCAT5 and they have it for free. They update it every 5 years, and I think we're due pretty soon. So, you know, that's there for you. That's a tool that you should have. You can print it out before you come, you know, cover a game. So when do you want to get imaging? You know, if there's signs of a brain bleed, you just want to do it. You can use, if you're working in pediatrics, you can use the PCON criteria. And also bear in mind if there's any concern for cervical spine injury. So going back to the fact that when the mental status is altered, you cannot rule out a C-spine injury. You know, you would want to get imaging just to rule that out. But things like, you know, MRI, not really that helpful because if they don't have a brain bleed, the rest of the concussion diagnosis is coming down to neurocognitive testing and symptoms. An MRI, unless you get a functional MRI, which is, you know, still isn't that great. We haven't honed in on the technology enough for you to rely on it above your clinical exam. There's really no need for an MRI. You want to get imaging if they meet PCON criteria for a brain bleed or if they have cervical spine issues. Baseline testing, another one, kind of controversial, not really that helpful. The one that's really in vogue right now is impact. It's variable utility because there's just so many, especially when it comes to kids, you know, I don't know how much you guys remember back, but imagine yourself at the beginning of ninth grade, halfway through ninth grade, and at the end of ninth grade. You know, there's a lot of development and maturing that went on in those months. Each month for a kid is huge. It's a difference. So unless you plan on doing an impact every, 3 times a year, it's not going to be that useful until you get to the point where you're much older. So say like college, where you're pretty stable at that point when it comes to development. Some of the pitfalls, kids are smart. They know that if they do really poorly on this exam, then they can go back to play sooner. Kids are smart, but they're stupid. And it's true, you know, there was a study that looked at, did a survey of UPenn athletes, and 22% of them reported hiding injuries, and I don't know, at least half of them said that they would do it again, and reporting concussion injury, and of that, half of them said they would do it again. So they're smart, but they're also really fucking stupid. There's also a lot of confounding factors, including improper testing environments, sleep deprivation, doing it after practice, doing it in a crowded room where there's a lot of distractions, because it's actually pretty intensive testing. And there's just a lot of variability between athletes, and it's hard to know how much of a change you're looking for when you're diagnosing concussion, or when you're looking if they're ready to go back to play. Because that's where, everyone says, well, if they get back to their baselines according to the impact, they can go back to play. I'm like, well, yeah, but if they're still having headaches and other types of symptoms, I don't really care what the impact says. They're not going back. So it's really not worth the money. Bottom line. And yeah, so we'll move on from that one. But treatment, well, when it comes to concussion, the number one rule to remember is when in doubt, sit them out. I can't repeat this enough. It's going to be on your boards. This is probably going to be the only question out of all of this that's going to be on your boards about concussion. And it really doesn't matter what the hell the situation is. If you even have a thought that they have a concussion, if you are evaluating them for a concussion, they can't go back to play that same day. Remember that, same day. Because what they'll try and trick you on is like, okay, well, they had a hit in the morning, but they're feeling great now in the afternoon, tournament situations. Can they play? Everybody, the whole championship is riding on them. It's like, fuck the championship. They're not going back that day. Next day, that's another story. That's something that's going to be real tough for you as a team physician, is making that call, because the issue is sometimes it takes up to 5 days for concussion symptoms to show up. Another thing that keeps me up at night, in addition to second impact syndrome, the fact that like the concussion symptoms might not even show up by the time I need to make a decision if that player can return, makes it real tough. In New York City, luckily, we have the law behind us. If they are suspected of a concussion, they have to have a doctor's note before they can return to play. So almost everybody in New York knows a fucking doctor, so they'll get, you know, their neighbor who's a dermatologist to clear them to return to play, which is great. But, you know, you reconcile that as you can. That's the name of the game in pediatrics. People are stupid. So when you are treating them, you want to do cognitive rest for about 24 to 48 hours. But then after that, you want to get their ass back in school no matter what. So even if they're just doing 1 period a day or auditing, not doing any assignments, not doing any homework, just sitting there, getting them back into their environment within 48 hours is key to their recovery, because you guys probably haven't spent time doing concussion work. What we see in the office is so much psychological trauma from not being in school. So because of the fact that they have a concussion, all of a sudden, you know, they may have gotten the concussion when they were doing, say, in physics, like circuit physics. And then if you keep them out of school, once they get back to school, you know, everybody's moved on to Newtonian physics, and they may suck at Newtonian physics. I got circuits, Newton, I don't fucking know that stuff. So, you know, think about it. And so they'll blame that on their concussion. And so there'll be this whole anxiety, anxious, you know, swirling thing. These kids are way too stressed out to begin with. And so this Herculean task of trying to get them caught up when they've been out, they're isolated from their friends, you know, and friends are shitbags, you know, they'll move on without them and leave them out of things, be like, oh, it's an inside joke, you were out, you don't get it. So this coming from a pediatrician, yes, I've dedicated my life to children, but the reality is like, it does so much psychological harm to keep a kid out of school. So all that to say, get their ass back in school, even if they're just auditing or doing 1 period at a time. You're going to do a gradual progression where you're going to be pushing the academics first and foremost more than anything. When it comes to return to play, that takes about 6 days to go through. We actually, John Letty, I guess it was now 2018 when it came out in December, and then 2019 in February, these articles showing that early light cardio activity can help reduce symptoms of exercise intolerance and help speed along healing of a concussion. So that's why we say, you know, you can do stationary bike. If they don't have vestibular symptoms, they can do jogging, anything that is kind of light. You know, I agreed. I'm pretty lenient. I'll let them do some push-ups and sit-ups and calisthenics if they want to, as long as it's not aggravating symptoms more than 1 or 2 points. So if they start at a 2 and they go up to a 4, that's fine. But if they're going up to 5, 6, 7, 8, then, you know, even though it's out of 6. But if they're going up more than 2 points when they're doing it, then that's when I say, okay, we need to back off a little bit. You're probably doing a little too much. So let's get more basic. But I try to make sure that they're doing something every day, so that we're not fighting deconditioning on top of, you know, concussion symptoms when it comes to returning to play, because it just muddles the symptoms. Plus, psychologically, it's a lot better for them to be doing something every day, even if it's stupidly simple. It feels good to do something, to be working on something, to be getting yourself back. So that's what I'll do with my athletes. But I'm always careful, you know, nothing where they can get hit by another player, where a ball can hit them, where they can fall off a bike, trip and fall. I say you can't get hit again. And they'll often say like, well, I was born in ice skates. I'm like, oh, that's great. I'm not worried about you. I trust you. I just don't trust everybody else on the ice. And usually that's enough for them to be like, okay. So the return to play protocol, cognitive physical rest, that's going to be for the first 24 to 48 hours. After that, we're going to light activity. This is where we typically stay for the duration of the concussion. If we're moving into something like post-concussive syndrome, sometimes I'll be nice to them and let them do some light drills with their coach privately, just to be doing something. The next step up to that are the non-contact drills. And what we're doing here is we're increasing the heart rate and the complexity of the movement. So what are they doing? Because, you want to be testing their ability to be moving up and down, their vestibular motor reflex. You want to be able to test their cognition and ability to concentrate. Plus, you want to also be able to test their ability to tolerate the exercise. So that's what goes behind this return to play protocol. You're increasing, because you're going to have to get creative when it comes to the athlete in front of you. There's hopefully it'll come out soon. The Concussion Center is doing a whole information thing for all the different sports, their version of a return to play protocol. But if you have to make it up on your own, just remember it's about increasing the complexity of the movement. So you're testing vestibular motor, testing ability to concentrate, follow visual hand-eye coordination, and also just the tolerance of getting the heart rate up. After, if they can do all of that, no issues, then they can do a full contact practice. If that goes well, then they can return to play normal gameplay. So in in general, I usually try to wait until I'd be comfortable with them just blowing through everything and going to return to play before I clear them. That's just my little secret. But a lot of my schools do have athletic trainers, but a lot of them don't. So I usually just wait. But the correct answer on the boards is a 6-day return to play protocol. An ounce of prevention is worth a pound of cure. So headgear, helmets can make some of a difference, but if you remember back to our definitions, it's an impulsive force to the head or to the body, or shearing forces of the axons with spinning in figure skating. So, there's only so much a helmet can do because the brain is shaking within the skull because it sits in fluid, right? So if someone asks, what do I do? We need something to go on. Well, the Virginia Tech helmet ratings can be very helpful. 5 is the highest, that's the best, and so that's what they want to be doing. Rule changes have also been very helpful. So no checking in Pee Wee hockey has actually reduced the concussion rate by 2/3. Pretty awesome. So having no checking, there is a huge controversy about changing the rules of football to reduce tackling. And that's why, in middle school and elementary school, we have flag football to reduce the amount of tackling. And then you're also not supposed to be doing upper limb and head contact in football as well. Soccer is in on it too, red cards for high elbows. And then also community education, because there's a lot of stuff that goes on and is talked about when it comes to concussion. There's even a whole Hollywood movie about it. I've had parents come up to me and very worried that their kid had a concussion and they're worried that they're going to become a murderer when they get older. And I look at them and I say, well, are they abusing small animals now? And the answer is no. I'm like, it's probably a safe bet that they won't end up a murderer. And it's funny, but it actually happened. That's a legitimate question that I had. So if you have the opportunity, if you're a sports doc doing any kind of community education, or if you work with sports docs, supporting them in doing that can be really, really helpful. Just a word before we end about post-concussive syndrome. This typically is symptoms for more than 4 weeks. In adults, sometimes they'll call it after 2 weeks, but generally when it comes to the Concussion Center, we'll call it after 4 weeks. Return to play, still contraindicated, even though that they're still dealing with some symptoms, some of them mild, might be just 1 or 2 symptoms that they just can't shake, still can't return to play. This is when I start compromising and letting them do a couple things privately with a coach or with their parent. It's very helpful at this point to refer to formal neuropsych testing with a neuropsychologist who specializes in concussion and post-concussive syndrome. It's a whole battery of surveys evaluating for anxiety, depression, learning disorders, neurocognitive testing, just like the SCAT, looking for executive function issues, those kinds of things. So what you can do, there's obviously cognitive behavioral therapy for the psychiatric aspects of it. You can refer to psychology and psychiatry. There's vision therapy if they have a lot of nystagmus, a lot of issues with their eyes, trouble reading. That's a common one, trouble with screen work. Vision therapy is really helpful, occupational therapy. Vestibular therapy, if they throw up every time they run to catch the bus, that's because the horizon is moving up and down and their Steadicam function is still off, so their brain cannot stabilize the picture that's coming in through their eyes. And so dizziness and nausea is a big thing with vestibular dysfunction, and there's a therapy for that. There's also executive function coaching. Pharmacotherapy is controversial. If you're getting into that, it's best just to refer to a concussion specialist or a neurologist who deals a lot with concussion. Be careful when you go into practice. It's really helpful to get to know the specialists around you, because just because someone is a neurologist doesn't mean they know what the hell a concussion is. So just be careful. We had an issue with a neurologist with one of our kids just completely mismanaging it to the point where it was a real messy case to deal with. So, with anything, if you're talking about hip surgery and you're a shoulder surgeon, make sure you know who you're referring to, because it reflects back on you. And that's all the sage advice that I have for you right now. Good luck on your boards. Hopefully this was helpful. I haven't taken your board, so I wish I knew more, but you guys are smart, so you should do fine. And oral boards too. Always say, that's a great question to buy yourself time. But anyway, good luck, and I hope you enjoyed it.